case for discussion today is a 52-year-old gentleman who presented with some weight loss and some chest symptoms. He was found to have a left upper lobe mass. On his CT scan, there was a suggestion of some left paratracheal adenopathy. The patient had a PET scan, which showed absence of activity outside the chest. The patient also had a brain MRI, which was appropriate to do, showing no metastatic disease involving the brain. That's kind of my standard workup, is a brain MRI and a PET scan to exclude extrathoracic disease. This was done, and in this patient, there was no evidence of extrathoracic disease. I think one of the important aspects of this case is that the patient had an EBUS, and there was documentation that the enlarged lymph nodes that you saw on the CT and PET scan were actually cancer. Squamous carcinoma was detected at the EBUS in the left paratracheal lymph nodes. And so we had a firm diagnosis and we had a firm stage. This patient was a T2N2, so well staged with a secure diagnosis of squamous carcinoma. So the physicians in charge of this patient did their job. They defined the diagnosis beyond a shadow of a doubt. It's squamous carcinoma, and they defined the stage. It was T2N2, stage 3A. Because it had multi-station N2 disease that was on the bulky side, this was by definition not a patient that should undergo surgical resection. So it would be, in our vernacular, unresectable stage 3A disease. In stage 3 disease, we don't know how to use the molecular markers or PD-L1 status. Now, I can tell you that many stage 3 patients do undergo molecular testing in PD-L1 testing. I don't think it's wrong to do that. What I do think is we should be honest and admit that we don't know how to use that information clinically, and we don't know whether or not any of those should factor into our decision making about what to do with a patient like this. When we went to the 8th edition of the staging system, there were several changes. Size has always been a important aspect of how big your primary tumor is. And there was lots of detail about that in the T staging of this. One of the areas that we saw an improvement, certainly not a perfection of the staging system, was in stage 3 disease, where formerly we had stage 3A and 3B disease. In the 8th edition, we added the stage 3C disease, which was based upon a more extensive primary tumor or N3 contralateral disease. So it further subcategorized the very heterogeneous group of stage 3 patients. Now, this is the 8th edition. It is in stage 3 disease, far from perfect. I applaud the committee doing this for thinking more critically about different subsets in stage 3 disease. One of the things that we don't yet have in the staging system, and this is particularly pertinent to stage 3 disease, are the size of the lymph nodes, the number of lymph nodes, the exact location of lymph nodes, those sorts of things, which I think is important in stage 3 disease, but aren't accounted for in the staging system. I think as we get to a 9th edition, 10th edition, and more information about that's where we need to be going into further subset the stage 3 disease. There have been a number of publications in the past that have suggested that really you could define 5 or 6 different subsets of stage 3 disease. Right now in the official AJCC staging system, we have stage 3A, B, and C, which I think is the right direction, but certainly not a perfection of the staging system. Categorically, I don't think it's changed practice. I don't think we necessarily use the changes or treat stage 3 any differently than we did before based on the staging system. But again, I do think that we are going in the right direction in terms of improving our staging of non-small cell lung cancer. The prognosis of this particular patient, if I saw this patient in my practice with bulky T2N2 stage 3A disease, and he was going to be treated with non-surgical treatment, and that would be with chemoradiation. And I think there are a couple of different platforms that we'll talk about in a moment. My counsel to this patient would be that you have about a 25% chance of being cured with standard concurrent chemoradiotherapy. If patients were to ask me on average how long would I live, I would say probably about 2 years. The issue with that is the patient would then ask me, well, am I above average or am I below average? And as doctors at that point, we aren't very good at prospectively prognosticating. We do know that if we were to see 100 patients like this, 25 of them would be cured. But when we saw the 100 patients, we didn't know whether it was 1 through 25 or 35 through 60 or just scattered patients throughout that were the curative patients. Now, the Pacific trial has changed that, which we'll talk about, but in terms of the standard of care pre-Pacific, those would be kind of the discussions I would have with patients like this.